Good evening. I want to thank you so much for joining us tonight for our second session of our Ovarian Cancer Wellness Symposium. My name is Taylor, and I am the Northeast Senior Regional Manager. And I would like to thank you all for being here. And this program is made possible by individuals and partners dedicated to providing learning opportunities and a platform for our teal community to be inspired. We would like to thank our presenting partner, Northwell Health, and our national partners, GSK, Merck, Asai, and Novacure, for making this program possible. In addition, I just want to let you know that this is a very important topic that has gone throughout all of our Teal Hearts Network support programs that is of great interest. So it is my honor to be able to introduce you to our speaker this evening, Dr. Andrew Menzin. Dr. Menzin is the Chief of Gynecologic Oncology in the Central Region of Northwell Health, as well as the Vice Chairman of Academic Affairs for the OBGYN service line. He is also a professor of obstetrics and gynecology at the Zucker School of Medicine at Hofstra Northwell Health. I would like to thank and give a warm welcome now to Dr. Menzin, who is going to be hosting our presentation tonight on My Treatment Ended, What Happens Now, Ovarian Cancer Follow-Up Care and Surveillance. So welcome, Dr. Menzin.
Thank you. Thanks. Can everybody hear me okay? Thumbs up? That's cool. Thank you. Well, Stephanie, it's a pleasure. And thanks to you for all the work you do on behalf of so many people. And you and your colleagues really are a foundation of support in a critical time in people's lives. And it makes a big difference. And it helps us do what we do. So thanks to you and everybody at the NOCC. And thanks to the folks that are on tonight. Stephanie asked me to share some background information about surveillance, like what happens after the primary treatment is done. So I'm going to touch on some things, and I will leave plenty of time so that we can have a bit of a dialogue, answer questions.
Dr. Menzin, can you unmute? For some reason, you are muted and we cannot hear you.
Can you hear me now?
Yes. Okay, perfect. If you could just, okay, I'm not sure what happened.
Oh, because before I thought people gave the nod, but can you hear me now?
Yes, absolutely. We can hear you now.
Did you hear all that nice stuff I said about you?
I absolutely did. So thank you very much. That was very kind of you. But we got up to the part where you said about sharing this information about follow-up and surveillance and what to expect, and then to then be able to have a dialogue. So we got to there.
All right.
Perfect.
So then we'll just press on. But again, some of these things may be familiar, some may be less familiar or not exactly what you have experienced, and we can talk about why. But this is hopefully going to level the playing field with knowledge a little bit. So we will press forward. I have no disclosures. It's something we often have to share, but no disclosures related to this topic. And just some background, ovarian cancer is the second most common gynecologic malignancy. The most common one is uterine cancer by far. However, as we're familiar with, it takes its toll, equal to that of uterine cancer and a little bit more because of its natural history, its behavior. And so it is one of our primary focuses. And according to the American Cancer Society, in this year, we expect nearly 20,000 new cases to be diagnosed. To put in a different perspective, there are almost 250,000 individuals in the United States in 2022 who were defined as survivors of epithelial ovarian cancer, people with a diagnosis, people in remission, people on treatment. 250,000 people, 250,000 people in this group. So it's a really critical group of people to attend to. And that's why the NOCC plays such a pivotal role in so many people's lives. And as you can see, according to the NCCN definition of a survivor, that individual is considered a survivor from the time of diagnosis, not after treatment, not after remission, but right from the time of diagnosis onward. And I think that's a critical thing. And I think it's important for people who don't have cancer to understand that and understand what that means. So with that background, moving forward to a little more, often when people have a suspicious mass, we will undertake surgery, what we call primary surgery. Sometimes that's laparoscopic or robotic surgery. At times it's an open procedure. Sometimes there are combined procedures where it starts one way, moves to another way. But the real goal of primary surgery is often to make a diagnosis. Many times people undergo a procedure with the potential for finding malignancy, and it's not always clear. Sometimes it's a very clear picture, where there may even have been a biopsy to confirm a malignancy. But one of the goals of primary surgery is often to make a diagnosis, help assess the extent of disease, where things are, what's involved, where in the peritoneal cavity, the abdominal cavity, are nodules, and where are there not. Okay, that's a critical factor. That's what we call staging, or assessing the extent of disease. And very importantly, in the setting of ovarian cancer, where the malignancy has extended beyond the ovary, it allows for the opportunity to do what's called cytoreduction or debulking, basically cutting out nodules, cutting out metastases from places that it's safe to remove them. There are occasionally places where it's not safe to remove, or it has grown in such a way that it is not prudent to remove. And in those cases, we have an alternate approach. But primary surgery is the cornerstone of ovarian cancer management, and that's followed in a multimodality approach with what we call systemic therapy, really. It used to just be chemotherapy, but recent times have seen an extension of the armamentarium that providers have to treat people with ovarian cancer. So it's not just surgery and chemotherapy. Now there are a variety of what we would call biological agents of many different kinds, of very, very varied mechanisms. New things are coming down the pipeline all the time. Combinations of things are being tried all the time. So it has been a very exciting and fast-paced few years. And the last 10, 15 years have seen an acceleration not only in agents that have been incorporated into ovarian cancer care, but the pace at which things move from research to clinical practice. So chemotherapy still is the cornerstone, the foundation of systemic therapy. Paclitaxel and carboplatin are the most common frontline agents. Those are the two that we use most often. There are occasions where we use other agents instead. Those really are the key best upfront agents to use. There's some other agents that we use, biological agents. We'll talk about that in a little bit, that come at the cancer cells from a different angle. So one of the ways that you can help destroy cancer cells effectively is to not just come at it from one direction, but to use a military term, to flank it, to come at it from different angles using different mechanisms of attack. And what that also does is it helps prevent what we call resistance, where cancer cells become kind of protected from within to the treatments that are given, which is a reason that that cancer cells survive despite treatment and can grow and progress. So by using a multimodality approach, it makes the treatment more effective and it improves outcomes. At times that can mean more toxicity, more side effects. So all of those things are balanced when considering what is the right combination, what's the right duration, what's the right sequence. Those are the important considerations that are undertaken when treatments after surgery are considered. And there are other targeted therapies, kinds of treatments that are based on what we would call personalized medicine, treatments that are targeted to abnormalities found when genetic analysis and other biological analysis is done on the tumor tissue to find what we might call actionable targets. So if a mutation or mechanistic change is identified that's associated with a potential treatment, that's something that may be considered at various points in a patient's illness. And those are often things that one may never consider without this new generation of testing of tumor cells. So you get a sense that the things in our toolbox have expanded. We're still working hard. It's nowhere near what we want it to be, but it's a far cry from what it used to be, and certainly far advanced from when I was in training. I mentioned earlier that sometimes things grow in places it's not safe to cut out, or sometimes there's an overwhelming amount of cancer right at the diagnosis. Sometimes people have had medical issues that preclude safe surgery, a heart attack, stroke, a pulmonary embolism, a clot that goes to the lung, other things. So there may be times where surgery first isn't the right course of action. And we do what's called neoadjuvant chemotherapy, where you get treatments before the surgery. And hopefully things shrink down, fluid dries up. That often can make the surgery that is done what we would call interval debulking, surgery in the middle, kind of the middle of the sandwich, safer, easier, less complex, with a better recuperation. So there are a variety of situations where we consider this neoadjuvant approach, but certainly primary surgery is the cornerstone of what we do. I just put on the slide here secondary surgery. When do we go back and take out more? There are really two instances, just for your own edification. When people develop a recurrence after a prolonged remission, they've been well, no sign of cancer recurrence, and then something develops. In general, if that has happened after a longer interval, at least 6 months, more preferably more than 12 months later, is an isolated, often single area, or something that is felt to be resectable, that is the best time to do secondary debulking surgery. There are times where we have to do secondary surgery, not so much to get the cancer cells out, but to palliate a problem, to fix a bowel obstruction, to fix a urinary obstruction, things of that sort. So secondary surgery has several different iterations, but the oncologic, the cancer treatment element of it, is best used when there's a localized recurrence after a prolonged remission. Okay, surgery generally isn't going to make up for a lack of effectiveness of chemotherapy. That's often a misconception or something that patients ask about. It's just not the case. And that can be a difficult conversation, but it's a critical thing to understand. So with that background, what happens when the surgery is done, the systemic therapy is completed, and hopefully a patient achieves a remission? Remission meaning there's no evidence of disease by physical exam, by symptoms, by blood tests, by imaging. Things look good. No sign of anything stirring up. What is the plan then? And that's really what Stephanie asked me to talk about. There are different considerations. Surveillance, meaning ongoing monitoring is an absolutely essential part of the health maintenance of patients with cancer. Okay, how often are you seen? That's something we're going to talk about. What has to be done during or before or after those visits, we're going to talk on and touch on. And very importantly, the ideas of health maintenance and wellness should not be forgotten or forsaken in cancer patients. That's a really important thing. A well-established core element of survivorship care is about wellness and health maintenance. The stuff that other people should be doing, cancer survivors should be doing. And we'll go through some of that. It often gets sidelined. It often gets put to the back, but it shouldn't be. Those things are very important to the ongoing health and well-being of ovarian cancer patients. So I want to start, though, by touching on maintenance therapy, because sometimes after that initial treatment's actually continued. It's continued to sustain that remission. That's what maintenance therapy is. So we've gotten someone to the point where there's no evidence of disease, and we know that ovarian cancer has a high risk of recurrence. What can we do that can help that chance of recurrence get lessened? How can we reduce or mitigate that risk? Various studies have shown at different times various interventions may be helpful, and that's what I want to talk about when we touch on maintenance therapy. So initially, the consideration was, well, don't stop the chemotherapy. Just keep it going. How long to keep it going? What agents to use? Those were challenging determinations to make. Because remember, these things are strong. Sometimes they're a challenge to get. Intravenous infusions can have logistical issues, and they have side effects. And some of those side effects are cumulative. The more you get, the more you experience. And some of them may not go away and at times progress. So while chemotherapy and extending the chemotherapeutic regimen on various schedules was initially considered and potentially effective, it just didn't seem prudent from a logistical or what we would call toxicity standpoint. Further research subsequently showed other agents that have been more recently developed were important considerations. Two drugs in particular are part of the current armamentarium. One is called Avastin, or bevacizumab, which is an anti-angiogenesis agent. So what that means is cancer cells grow and proliferate in an unchecked fashion. Most normal cells in the body, as they divide, have contact inhibition. When they touch each other, they stop growing. Okay? Cancer cells don't do that. Despite that contact, they keep growing. They grow over themselves. It's this unchecked growth that is the nature of malignancy. Part of that is those cells need to get nourishment, and nourishment comes from blood vessels. And one of the characteristics of cancer cells is that they cause the body to produce new blood vessels through secreting various molecules. Avastin is an agent that attacks the formation of these new blood vessels. It basically cuts off the supply mechanism for the cancer cells to receive its nutrition. And that has been a very effective approach in a variety of cancer scenarios, in particular with ovarian cancer. If the cancer cells can't get their nutrition, they can't grow. And so at times Avastin is used upfront in certain settings with the chemotherapy as an initial plan, but also Avastin may be continued as a maintenance therapy. And that's been a very effective intervention. It's not continued forever. It has some potential significant side effects, but just to give you a sense, between the primary treatment and the maintenance treatment, people can get up to about 15 months, so a bit more than a year of that kind of treatment. A different agent called a PARP inhibitor. I put the name on the slide if you really wanted to see it, but it's a little hard to kind of even say. So everybody just calls them PARP inhibitors. Currently, there are 3 that are available. They're not exactly the same, but they all have similar mechanisms. And basically what they do is they help attack DNA, the genetics of the cell. They block the repair mechanism, okay? So they basically create a situation where the cancer cells can't fix mistakes that occur, and that leads to death of the cell. Interestingly, these PARP inhibitors have been shown to be effective in a broad array of scenarios, but especially in patients who have hereditary predisposition, the BRCA mutation, or some other kinds of genetic changes that are different from but relate to the kinds of things that occur in BRCA patients. So PARP inhibitors have actually been shown to be another very effective potential maintenance therapy. These agents are sometimes used for up to 2 years, okay? As long as people are tolerating the medication, side effects are not prohibitive, and there's no sign of recurrence. So agents aren't continued if there's sign of recurrence, they're stopped, but without recurrence, generally up to 2 years. These are strong medications, oral medications, so they're logistically a little bit easier, but they can have not insignificant side effects. And that has to be managed in the context of what a patient experienced with their primary treatment and what develops afterwards. But maintenance therapy is really a critical element to consider. How do we sustain a remission and mitigate the risk of recurrence in this cancer that we know has such a high chance of coming back? So how often should surveillance be undertaken? And I know people probably have experienced different things from different doctors, perhaps even different specialists have recommended different intervals. I can tell you in my practice, what I usually do is see patients every 3 months for the first 2 years. If all is well, they're doing well, no signs of recurrence, no active treatment, I'll then see them every 6 months for another 3 years. That puts them at about 5 years. And I tell patients, I give them the instructions and precautions that, hey, if you're being seen in 3 months or you're being seen in 6 months and something happens, don't wait. Call up, be proactive, be an advocate for yourself, contact your providers, and get seen sooner. Okay? That's really important. So I kind of frame it as if everything's good, come back in 3 months. If something's not so good, come back sooner. Now, if you look at this slide, it says 2 to 4 months for the first couple years, 3 to 6 months for the next few. Why is there that interval? How is that okay? These are based on the National Comprehensive Cancer Network guidelines, a series of guidelines that are produced based on evidence-based information by various panels of experts that are very knowledgeable in the area of the cancer specialty that they're working on. With that said, the difference between 2 and 4 or 3 and 6 may seem like, how can that be so variable? Is it 2? Is it 4? Is it 3? There isn't evidence to show that one is better than the other. There just isn't. It's a judgment, okay? On the one hand, you want to watch people closely. On the other hand, you want to give people the needed break from doctor visits. It's stressful, as you well know, just coming to the doctor. Sometimes it's a hard thing to get to the doctor, but just that visit, the anticipation of the visit, the experience of the visit, and the information that comes along with it can be a stress in and of itself. So that's a consideration too. But usually that sweet spot for me, if everything is well, is 3 months. Okay. Sometimes we actually see patients with other providers. So for example, in my practice, my partners and I don't deliver chemotherapy. We do the surgery. Some GYN oncologists do both. We work with medical oncologists. So one thing that we have at Northwell is we have what we call a multidisciplinary clinic where patients will come in, this is during their surveillance, come into one place at our cancer center and see the medical oncologist and me, and sometimes the radiation oncologist who were cervical cancer patients or endometrial cancer patients, all at the same time. Patient comes in one place, doctors come to them. This way they don't have to keep going to a lot of different places. Makes it a little easier. Actually, we think it provides as good or better care, and it really helps the patient get what they need in just a more efficient and, we think, kind way. But if you understand that there are different schedules that are not unreasonable, that variation becomes recognizable. After about 5 years, we usually see people once a year. I can tell you, I've been in practice now for almost 29 years. There are a few people I still see every 3 months that have been my patient for 15, 20 years. Why? It gives them comfort. Okay. I tell them, do I turn you away? No. Is it necessary? Of course not, if they're doing well. But does it make them have peace of mind and comfort? Yeah. So why is that bad? Now, that doesn't speak to whether an insurance company pays for it or not. Those are not issues that I really want to delve into. But, when Stephanie asked me to touch on the schedule of surveillance and the variation that some doctors may recommend, I really wanted to make a point of sharing that, because I think even people who, listen, I have actually 2 patients that I still see from my first month in practice in 1995. Okay. And I love when they come in, because it's more social than medical. But do they really need to see me 28 and a half years later? No. Okay. But that's part of being, in an alliance with someone, right? We're here to provide more than just medical care. We're here to provide support in a variety of different ways. That's why I put that last bullet item down, shared decision making. Okay. That's where it's not just the doctor saying, here's what you do. And it's not just the patient saying, here's what I want. It's people coming together. What is reasonable? What is prudent? What is acceptable, right? Is there more harm than necessary? Okay. Is this helping more than it's hurting? So for understanding the challenge and the stress of coming in, for some people, staying on that schedule actually reduces their stress, right? And understanding how different people react to the concept of surveillance is really important in getting it right for each individual person. So what's done at those visits, right? And I'm sure you guys have experienced all manner of variation. A physical exam is part of it. A pelvic exam, I think, should be part of it on a regular basis. Obviously, if someone's seeing me, I'm doing a pelvic exam every time. Okay. I think that's important because one of the places we want to look for recurrence is in the gynecologic area. And we do that by looking and palpating. Other docs may not do a pelvic exam because we're part of the care team, and that's fine. But it's important to have that on a regular basis. The physical exam should be a general survey, comprehensive evaluation looking for various abnormalities. Okay, so it's a comprehensive physical exam, a comprehensive inquiry as to symptoms, side effects, things of that sort. So open-ended questions that may elicit information that a patient may not have even thought to share. But when you prompt them, they say, oh yeah, well, maybe I'm having this. Or, hey, I noticed this on your exam. What about this, right? It's a dialogue. It's an alliance. Laboratory tests are common. We usually focus on the markers, the CA-125 in particular for ovarian cancer. Sometimes other markers are obtained, but really the primary one is CA-125. If someone has had a marker panel that showed an abnormality in other tests, we'll often follow that in a sequential fashion. And some types of ovarian cancer, the less common types, are associated with other markers. So it really is an individualized process. And knowing what a patient's basic blood type or blood tests are, the CBC, the blood count, the white blood cell count, the platelet count, the chemistries, the liver function, the kidney function test, can really be a helpful thing in knowing how people are doing with prior treatment, where their levels are, and sometimes put into context symptoms. Are people fatigued? Is that related to anemia? Might they be having some longer term, later effects of chemotherapy that may show up in a variety of blood tests? So those are common things that we'll do at each visit. Imaging is a complex question, right? There are people that get scanned empirically, meaning on purpose without an indication other than for surveillance as a routine. What's that schedule? Might be every 3 months, 6 months. It's hard to know. It's variable. Depending on the test, it may not always get approved. They can be expensive. Sometimes if you're getting scans of various types, that could be a fair bit of radiation on a regular basis. That can be of concern. We worry about what are called secondary malignancies, whether it's from chemotherapy or other treatments. So what is really the standard? Well, there is no absolute standard outside of a clinical trial. When somebody is on a clinical trial, the surveillance, the monitoring, including examinations, what those exams should be, the blood tests, the markers, and the types of imaging and when are strictly prescribed. Falling off of that plan is a protocol violation often. Outside of a clinical trial, there's wide latitude in what providers can and may do. And so comparing what one person may have had to what another person may have had doesn't mean one's getting better care or less good care. Doesn't mean one doctor's right and the other doctor's wrong. It's a matter of judgment. It's a matter of personal approach. And it's hard to, but important to understand that variability still falls within accepted guidelines, okay? Oftentimes, we don't get scans, we, meaning my partners and I, unless the blood tests are abnormal, the exam is abnormal, the markers are abnormal. Yet, some of our colleagues who are watching patients with us may order scans on a regular basis. I typically don't tell people don't get the scan someone else has ordered for a variety of reasons. It's not my place to tell someone not to do what some other doctor has told them, I feel. And frankly, sounds weird, but I'm pretty superstitious. I don't, it's, and I'll come back to the superstition thing when we talk about ports. What test is best? People say, well, I want a PET scan. PET scans are used for specific indications to assess specific things. There is no single test that's perfect for everybody in every instance, or we would just do that all the time. Okay? MRI isn't better than PET or CAT scan. PET isn't better than both of them. It's like using a different camera to take a picture. Okay? I know everybody just uses their iPhone now, but you're looking for different things. At times, people can't have a CAT scan because of an allergy. They get an MRI, or they have a reason not to get radiation, and they get an MRI, or they can't get an MRI because of the magnetism and certain implants that they have. So there's also some individual variation, but there is no one standard, okay? And I understand that that can be a challenge for patients to accept. Genetics evaluations have changed over the last several decades. The information about the hereditary risk associated with malignancy and ovarian cancer in particular has grown enormously. It's actually now not even just a preventative intervention, right? So that you understand your risk of malignancy. But as I alluded to before, with the advent of PARP inhibitors, it can change therapy. It can predict outcomes. So the power of understanding hereditary risk is as it's never been before. And thankfully, a genetics evaluation is part of the standard for patients with ovarian cancer. In particular, invasive epithelial ovarian cancer. Some other less common types don't typically indicate the need for a genetics evaluation, but the standard, the typical, the common form of ovarian cancer, high-grade serous ovarian cancer, is associated with an automatic indication for a genetics evaluation. And that's really a critical thing to help manage that individual's risk as well as the family's risk, but also potentially to guide therapy. With her, I mentioned the whole concept of long-term wellness. One of the things that I try and incorporate into my practice is a variety of health maintenance issues. A lot of times now, people see a bunch of specialists. Everybody has their particular little niche that they take care of, okay? And they don't really get into anything outside of their narrow lane. And that's okay, but I think cancer patients are served better when their providers are aware and support health maintenance care. In particular, nutrition and weight management. Now, am I an expert in nutrition or weight management? No, but I may inquire and support them speaking to other providers to get what they need, if that's a concern or a desire. Physical activity, we talk about that all the time as it relates to just wellness, emotional wellness, physical wellness, but frankly, bone health. The more active you are, the stronger your bones are. The more active you are, the better you sleep. And sleep hygiene is something that can be a real challenge for cancer patients. Getting enough rest is a hard thing for all of us. I am not the poster child for getting enough rest, okay? But I think about it a lot. I try, and I talk to patients about it a lot. Because fatigue is a real challenge. It limits what you do. It limits how you feel when you do what you want to do. And it is essentially the way we recharge our battery, right? Just today, I was talking to families about their loved ones' recuperation. And I said, listen, both times I reminded them what I said at our counseling visit. People are more fatigued than they expect. They just are. They don't anticipate the degree of fatigue that they experience after surgery. Same thing with chemotherapy, right? Your body takes energy to mend, reduces the energy in your battery. That's why you're tired. That's why you sleep. so you can build up that energy, recharge your battery. You know, getting cancer is a challenge of epic proportion in someone's life. But it's also a moment in time where people may pivot certain health habits. It's a time where people may consider tobacco cessation. And it's an opportunity where people may focus on certain changes that they can make. And this is a critical one to explore with patients. It may be something they don't want to do, or they may not feel this is the time. But again, opening up that discussion is a vital part of provider wellness support. Vasomotor symptoms for menopausal management can be a critical part of the discussion. Vasomotor symptoms can be disabling. They can last for a long time. The challenge of managing them with hormones or other agents can be not a minor thing. And there are providers that have a specific focus on this, but not addressing it, I think, is a mistake, and it doesn't serve patients well. Other health maintenance issues that are absolutely vital to keep up to date are breast health maintenance. Breast health maintenance is not about ordering a mammogram. That's an easy thing for doctors to do, okay? But breast health care is three things. It's the doctor ordering the appropriate imaging, depending on the scenario. The patient, in my opinion, checking themselves. Has that always been shown to make an improvement in outcomes? No. And it can lead to some referrals that may not be necessary, but I think that breast self-exam, in my opinion, is a patient being an advocate for themselves and being their first line of defense. And then it's the doctor doing the exam. It's those three things. Osteoporosis prevention, critical. Okay. The fractures don't kill you. The sequelae, the downstream effects of the fractures do. They displace you. They take you out of your environment. They can lead to consequences like blood clots, pneumonia. Having strong bones makes you healthier and live longer. Goes back to nutritional management, weight management, and activity. In colon cancer screening, again, something we advocate very aggressively for because of the population risk. No one likes going for a colonoscopy. The prep is terrible, but it's doable. And however an individual and their provider elect to do colon cancer screening, it's just such an important thing. With regard to sexual health, often a topic that patients are reticent to bring up, but it's really important that people who want to pursue relations understand the limitations they may have and what's safe and reasonable to consider. It's not something that they have to forego necessarily, but how they incorporate into their lives after surgery, after treatment, after the changes that go on with various treatments is something that providers can really help with to optimize and enhance patients' wellness. So one last thing, Stephanie asked me to touch on the removal of the port. You know, unfortunately, I don't have an answer, okay? There is no standard answer that I am aware of. Ports are a very effective way to minimize the discomfort and stress of constant blood draws and IVs that can really plague an individual going through chemotherapy. But when do you take it out? Some people take it out when their planned course of treatment is done and they're ready to get it out and they want it out. Other people don't want it out. Okay. And some people, I mentioned earlier how superstitious I am. Some people are very superstitious. If I take it out, I'm in remission. If I take it out, that means the cancer is going to come back. Okay. And while we know that that's just not the case, it's just how they feel. Okay. So do I have patients that have had a port in for a long, long, long time and have, that have to go for the regular port flushes and things like that? Yes. But if that gives them comfort, if the device is not causing them harm, they can manage the logistics. It's what they have to do to get through the day to feel comfortable. And again, if they can accomplish that in collaboration with their supportive provider, I don't have a problem with it. But by and large, can it come out after a period of time following the completion of treatment? Yes, it can come out safely. And if a new one needs to go in, a new one needs to go in. So I hope that kind of addresses with a non-answer the question. I thank you. I fear I went on longer than I was supposed to, but I hope this gave you a little bit of context. And I'm happy to answer any questions. I do very much appreciate your taking the time tonight just to be together.
Dr. Menzin, that was excellent. And I will say this, I can see why your patients stay with you for 28 years. I cannot thank you enough for being so comprehensive and frank. And we had some questions that came in prior to tonight's call, and then we have some that are in the chat. So I'm going to begin with one of the questions that came in prior. If we are receiving follow-up care from our gynecologic oncologist, do patients still need to have regular visits with their prior gynecologist?
So not necessarily. A lot of times I will do their care. It depends, again, on what the G1 oncologist is comfortable doing. Okay, you want to make sure the patient needs to be an advocate for themselves. So they need to make sure they're getting breast care, that they're, getting bone health management, things like that. What we would call well woman care. I have patients that have had a strong and really deep relationship with their gynecologist before they ever came to see me. Okay. And so what I tell them is it's perfectly fine to see your gynecologist for an annual visit to do those well woman care things. If they don't, then I will do them. Okay. Sometimes there are things that the primary care doctors do, because many primary care doctors, not all, but many, will do a variety of well woman care things like bone health, breast exams, and the like. The thing I try and do is determine who is doing what, so that a patient understands what doctor is doing what for them, and the doctor understands what the patient expects from them. Okay. Just to give you an example, so that I'll ask a patient, if I'm not doing their breast care, I'll say, last time you told me, or you've been telling me your primary care doctor does your breast checks, right? Yeah. Okay. Because I just want to make sure you're up to date on that and getting that. And remember, it's not just the mammogram. They're actually checking you, right? Okay. Well, then go back to your primary care doctor and ask them to do an exam. Okay. Because breast care is three things. It's not by committee. It's not one doctor orders the mammogram, one doctor does the exam, in my opinion. Because a normal mammogram doesn't rule out breast cancer. A normal exam doesn't rule out breast cancer. The combination of things looked at in totality assess the risk of breast cancer. Okay, so that's how I approach that particular issue.
Thank you so much for such a thorough answer, and we greatly appreciate that response. The next question I'm going to take from the chat is, can you explain HRD if someone's tumor tested positive for HRD and that's why they are put on a PARP inhibitor? Can you explain to the audience what HRD is and why that would lead to a PARP?
it's it's a genetic change that's similar to the changes that exist in a BRCA patient, and HRD would be in someone that doesn't necessarily have a mutation. So if somebody has a mutation, that's the relevant thing, okay? But if they don't and they have that, then they may benefit. It's a molecular genetic assessment of the tumor, okay? So it's tissue that's taken out and assessed in a lab, and a report is generated. And if that is found to be documented, a PARP inhibitor may be of benefit. Now, will it be a benefit to the same degree necessarily as someone with a BRCA mutation? Perhaps not, okay? Will it be a benefit to a greater degree than someone without that? Perhaps, okay? So it's a way to uncover the potential value of those medications in certain settings when a genetic mutation is not present.
Okay, so we're going to go right from that into the next question. If someone does not have any hereditary markers, is there any type of maintenance therapy available to those individuals?
Well, depending on the setting, and again, in general, the way for us, the medical oncologist or the G1 oncologist would assess things is based on their hereditary predisposition, based on their molecular analysis, right? And based on the treatment that they got up front. Was Avastin given or not? Those factors would be used to determine, in addition to the extent of disease and the specific scenarios of their malignancy, whether maintenance therapy would be appropriate. So it can vary, and each individual case is just that. But right now, it's really Avastin versus a PARP inhibitor.
Thank you very much. Another question that came in before tonight's program. You had shared that at Northwell Health, you are the surgeon, and then patients go and see medical oncologists, and that you work together in patient care. If a patient has been NED for a year and a half, and they have been under the care of their medical oncologist and has not gone back to a gynecological oncologist, the person that did their original surgery, how often should they be seeing the surgeon as well as the medical oncologist if they are NED?
So if they're out for a year and a half and they were in my practice, sometimes what happens, because we see scenarios like that, generally what'll happen is the medical oncologist will realize that they haven't seen me in a year and a half, and they'll say, you got to go back and see Dr. Menzin for a checkup. So at that point, I'd still be seeing them every 3 months. But, then, at 2 years, I'd say, okay, let's spread it out to every 6. Could you make an argument that if they're being followed by a medical oncologist who does a thorough exam and they're not having any gynecologic complaints, do they need a pelvic exam? You could make an argument that they don't. And that's why those NCCN guidelines will say, which include pelvic exam as clinically indicated. So if you ask a gynecologist, you should have a gynecologic exam, but is a medical oncologist going to do a pelvic exam? Probably not. If you were seeing a gynecologic oncologist for your chemotherapy surveillance, you're probably having a pelvic exam. So just like we alluded to the variation in practice patterns that are within the standard of care, that's a pretty wide variation. Now, if, for example, you're seeing a medical oncologist and it's hard to get back to the G1 oncologist for a variety of reasons, whatever, but you're having a concern or a symptom, got to go back, right? Or not going back is imprudent. Or the medical oncologist, say, who knows about the symptoms and doesn't encourage you to go back, is probably missing an opportunity for you.
Excellent answer. Thank you so much for clarifying that for our audience tonight. I think a lot of the women on this call appreciate that. Another question has to do for recurrence. What types of symptoms should patients be looking for after they finish their frontline treatment?
Well, I mean, I think, when I kind of share with people what precautions they have, I mean, the usual things we talk about are pain, bleeding, discharge, changes in urinary or bowel habits. But I also kind of put into context that I say, you're still a regular person, right? You're still going to get stuff. You may eat something that doesn't agree with you, and that doesn't mean the cancer's come back. So the way I try and frame it is, if you start to feel something, obviously bleeding or discharge are a different thing, but pain or GI or urinary issues, if they don't get better in a reasonable amount of time, if you go a few days and you're still not feeling good or you're getting a little worse, tell your doctor, right? But if every ache or pain makes you overly anxious, that's not good too. And we want to lessen that experience. Okay. So that, okay, I don't feel good. Let me just see how that goes a little bit. I mean, again, assuming it's not some severe manifestation of a problem, you give yourself a little grace. You give yourself a little bit of an opportunity to let your body mend itself. Not too long, but you give yourself a chance to heal. And if that doesn't work out, reach out and let somebody check you out. And it may very well pan out not to be anything bad. But you've given yourself that latitude, and then you've been cautious as well.
Excellent. Easing the patient's mind is always key. The next question you actually answered was pertaining to ports, but I'm actually going to tie it into a question that came in beforehand related to the ports, because you did discuss about keeping them in, taking them out. But the other question that came in prior to the program this evening was, how often, if you do have your port in, should it be getting flushed if you are not on active treatment?
Frankly, it's not part of my practice. So my recollection is once a month. That's what I recall. The main thing you don't want to have happen is you don't want it to get clogged, right? And that's what the flushes are for. So regular use will keep it from getting stopped up. It's like a drain. That's really the critical thing. And obviously you want people who know what they're doing to access the port. They're made in a special way so that using very specific special needles, the diaphragm will remain functional and safe for a good long time. So you just want people who know what they're doing it and doing it regularly. But I believe it's about a month.
Thank you. Next question pertains to, do you have to be no evidence of disease to be on a PARP, or can you have disease at the microscopic level?
Well, having disease at the microscopic level would be undetectable. So, one of the challenges is to help people understand, for example, well, if I had cancer confined to the ovary, why do I need treatment, right? If I have a stage 1 cancer, why do I need treatment? It's out. You're not treating metastases that you could see or that you happen to see and removed. Excuse me. And the reason we do that is because of a risk of recurrence in certain settings, and certain factors help us gauge that risk of recurrence. So if the risk of recurrence is greater than, for example, the risk of side effects of the treatment, on balance, you would benefit from the treatment to reduce the risk of recurrence. But to the point of your question, what is recurrence? Recurrence are cells that grow back. So that there are cells that are in the body that, despite treatment or surgery or time and the body's own defenses may linger and eventually grow. Those cells may exist in an undetectable form. You may not feel or see anything abnormal, but they may exist. And it's that risk of those things being present, those cells being present, and that risk of those cells growing is the indication for treatments in certain settings. If the likelihood of you having those cells is so remote that side effects are more likely than something growing back, you don't do it. Some cancer cells can remain dormant for an incredibly long period of time. What are called borderline tumors of the ovary may exist and recur 15, 20 years later. And I've actually seen it. Most of the time they don't, but it can happen. And you think to yourself, something can live inside of me or exist for that long and then sprout up. What caused it to then flourish after it's been dormant for so long? That we don't know. But it is the fact. And so that's the goal, for example, of maintenance therapy. When you don't see anything left, right? You want to not just keep it in check, but sustain that remission, and hopefully giving a bit more may further reduce the chance of it coming back, hopefully without greatly increasing your risk of negative consequences of the treatment. And some people may say, I don't care what those consequences may be. I want to reduce my chance of anything coming back. But remember, some of those consequences can be even life-threatening.
Thank you for explaining that to everyone tonight. Could you touch upon the blood tests that patients may be hearing about to monitor cancer on a continued basis?
You mean beyond CA-125 and
Yes,
like cell-free DNA or
exactly.
I think they're exciting opportunities for diagnosis and monitoring. I think that they, in my opinion, await their proper place in health maintenance and surveillance. Not uncommonly, technology outstrips our understanding of how to use it. People latch onto things, and yet we don't know how precisely to incorporate it. So I think the concept is interesting and exciting. I don't know that we're at a point now where it is part of the standard armamentarium. Might it be? And might it be soon? One would hope. But I think it's not that I don't want to be an early adopter or be a naysayer. I just think that really understanding what it means, how it can be useful, is critical to using it well. And for example, similar but different scenario, not uncommonly, you can read in the lay press about people advocating for patients pushing their doctors to get a CA-125, and there are stories that abound about how people have advocated for themselves, gotten testing, whether it's the blood test or scans, found things that would have otherwise might not have been found, and their lives were changed and saved, hopefully, right? What you don't hear about are situations where people had, for example, a CA-125 just to see. It was abnormal. They ended up getting referred to people like me who can't ignore a blood test, and then they have surgery that they might not need it. And anytime you do a procedure on somebody, you carry risk. that even can be a life-threatening risk. And you don't really hear about those kinds of things. So the point I'm making is understand what the tests are, understand what the indications are for their use, their benefits, their limitations, and their risks. So I think those things are really kind of cool and exciting. I just don't think that, to my understanding, they are ready to be used ubiquitously. They need to be understood more.
And it goes back to your shared decision making, that discussing it with your doctor is the best thing to do. I think that's we can remain hopefully optimistic in our community that there's still going to be things that come on the horizons for us.
And those things are really exciting. I mean, if you think of the potential power, but we also are aware in the news about things that looked great, turned out they weren't so great, or so I think the stance should be cautiously optimistic.
Well, thank you very much for that. And I just want to be respectful of everybody's time. Dr. Menzin did leave the OR and completed a surgery tonight to join us. So I'm just going to try to ask him one or two more questions. And if someone had genetic testing when they were originally diagnosed and it was negative, do they need to have it redone every few years as part of their ongoing surveillance?
Generally not, would be my first answer. But my deeper answer would be, it depends. So why does it depend? Because it depends on what they had done and how it was done. So, which may seem like a kind of non-answer again. But if you had very targeted therapy looking, or targeted testing looking at little bits of information, and that was reassuring, that may not be the comprehensive assessment that's done now, for example. And if there's an extended interval from when testing was done, there may be new genetic markers that are assessed that weren't assessed or not assessed in a certain way previously. Okay. So I think the thing to do in those situations, and my personal preference, is to work in collaboration with our genetic counselors, our cancer genetics team that we have, because, access to genetic testing has expanded greatly to the very much benefit of patients. The challenge is that it isn't always done in the setting, again, in my opinion, of optimal counseling, both before the testing and after the testing. So the access has improved, which is good. The counseling, which I think is a critical part both before and after. It's not just your test was negative, that's awesome, bye. It's how do you interpret a negative test in the context of your personal and family history, right? Most people who order the test probably aren't equipped to answer those questions, okay? It's the number of genetic counselors is limited. But we have, our team does a really good job. A number of places do a really good job. And I think that's an important thing. So just to kind of get at your question, if you had genetic testing, say 10 years ago, right, it might be reasonable to inquire about a consultation with a cancer genetics service, just like you might go to another doctor, right? Those things are mostly done virtually now, which is very convenient. You share the information from what you had before. You share new information that may have been uncovered about your family history or your personal history. And you have a discussion, right? Pre-test counseling. Is additional testing indicated? What's the harm there? Yes, do it. No, don't. You're good.
Profound words. Thank you. And I think this is an important question that we'll have as the last question for tonight. Is there a link between breast cancer and later development of ovarian cancer?
So breast and ovarian cancer are clearly linked with regard to the BRCA mutation syndromes. And I think that understanding was a profound advance in cancer care years ago, changed the landscape. It was beyond just family history, right? But I think it's important to realize that there are people who get both cancers that don't seem to have a hereditary predisposition, a formal genetic mutation that's identified. And people who have breast cancer, and studies have looked at this, what's their risk of getting ovarian cancer? People who have ovarian cancer, what's their risk of getting breast cancer? And, breast cancer is just very common, regrettably. It just is. So it may be hard to tease that out. And I think really the message here isn't to make people worried. It's to make people aware so that they get what they need. They get the care they need. They get the checkups they need. It's also not to have people get what they don't need, to get what's not indicated just because they're scared or concerned. That may end up leading to harm, right? May just be a blood test or something like that. But if you don't need it, don't get it. If you need it, get it. You don't need it, don't get it. But in my opinion, there is a link. Clearly, there's an identifiable link with regard to people who have a mutation, but even people who don't seem to have a greater risk. And what is the basis of that risk? Is it a hormonal thing? Is it something that we just can't put our fingertips on? Perhaps. As much as we know now, which is more than we knew, there's still a lot we don't know.
Thank you for being so thorough in your response. And there's one more that I'm going to sneak in here. If one PARP inhibitor does not work, could somebody still try another one? Can you switch from one to another? Is that something that's possible?
It is possible. Again, depending on the specific scenario, what were the circumstances where the other one was stopped? Was it a side effect? Was it a failure? What was the exact setting? All of those things go into the question of retreatment. What's the interval from when one was used to, when one might be considered? Is it that one was used for a while, there was an interval, and now one might be considered at a later time? So there are many permutations that one could consider. It's not often done, but it's certainly possible.
Okay, thank you very much. So with that said, there are some other questions that are in the chat, and I will send them over to Dr. Menzin. And if he wouldn't mind, I will get some answers and then share them with those people that joined us tonight. But what I would like to share is one comment, because I think this says a lot. Thank you for an excellent presentation, Dr. Menzin. If you could clone yourself or train others to be as approachable, knowledgeable, and caring, we would have more ovarian cancer survivors. And I reiterate that, and I can't thank you enough for doing this, taking the time out of your busy schedule to help educate and inform those people that are part of our teal community so they can make decisions with their healthcare team. So I thank everybody for joining us tonight. Thank you so much, Dr. Menzin. And I hope everybody will consider joining us for our third session, which is next Thursday evening at 6:30 p.m., November 9th. And it is going to be on reflections of beauty, ovarian cancer treatment, and self-image. So thank you all and have a wonderful